Hello viewers, I am Dr. Rabiul. I work as a lecturer in pathology in a medical college hospital, and I am making this video for my students and also for you. Hope someone finds this helpful. Today's topic is on inflammatory bowel disease. This video will contain the definition of inflammatory bowel disease, followed by discussion on the two conditions that comprise inflammatory bowel disease. So we will talk about their epidemiology, pathogenesis, morphology, clinical features. We will also talk briefly about the differences between the two conditions that comprise inflammatory bowel disease, and at the end we will also discuss briefly about their treatments. Okay, so a lot of topics, so let's begin. First question, what do we mean by inflammatory bowel disease? How can we define this disease? So, as written in your textbook, inflammatory bowel disease can be defined as a chronic condition resulting from inappropriate mucosal immune activation. Okay, I hope you're still with me. You didn't run away just like my students do when I try to teach them definitions of pathology. I even have to show them teddy bear to keep them calm. So look, I am also showing you a teddy bear to keep you calm. So don't run away, look at the teddy, because I will try to explain this definition line by line now. Okay, so what did we see in the first line of the definition? Inflammatory bowel disease is a chronic condition. Now, what do we mean by chronic condition? That means it is a persistent disease, it is a long-standing disease, so it is chronic in nature. And when we will talk about the clinical features of inflammatory bowel disease, we will also learn that inflammatory bowel disease is a disease that is of course chronic in nature, and also it will have a period of active disease, and also those periods of active disease will be interrupted by some periods of asymptomatic time during which there will be no symptom of the disease, and those asymptomatic periods can also last for weeks to months. Okay, so always remember that inflammatory bowel disease is a chronic condition. And what did we say in the next line of the definition? Resulting from inappropriate mucosal immune activation. Now, what do we mean by that? Always remember, our body has an immune system that protects us from different harmful microorganisms, but sometimes the immune response can become inappropriate, and in this case we are seeing that there is inappropriate immune response happening in the mucosa of the intestinal tract, and we will talk more about those immune responses when we talk about pathogenesis. So I'm repeating the definition one more time for my students. So inflammatory bowel disease can be defined as a chronic condition resulting from inappropriate mucosal immune activation. So now that we have defined the disease, now we will move on and talk about the two conditions that comprise inflammatory bowel disease. Always remember, inflammatory bowel disease comprises two conditions. They are Crohn's disease and ulcerative colitis. So we will talk in details about these two diseases. For the moment, let's now focus on the epidemiology of inflammatory bowel disease. Now, inflammatory bowel disease can occur at any age. However, it is frequently seen among teenagers and also among young adults in their early 20s. Both sexes can be affected by this disease. However, ulcerative colitis is slightly more common among females. Now, inflammatory bowel disease is most common among Caucasians, and in your textbook you will see a very interesting finding, that is, in the United States, inflammatory bowel disease occurs 3 to 5 times more often among Eastern European Ashkenazi Jews. Why is this disease happening 3 to 5 times more often in the Ashkenazi Jews population? Well, it is partially due to the genetic factors. Okay, so genetics will have a role in the pathogenesis of inflammatory bowel disease, but as we will see later when we talk about the pathogenesis, that the precise mechanisms that lead to inflammatory bowel disease are still not well defined. And regarding the geographic distribution of inflammatory bowel disease, always remember that the geographical distribution of this disease is extremely variable. However, it is seen most commonly in North America, Northern Europe and Australia. But the incidence of inflammatory bowel disease is rising worldwide, and one interesting finding that we see is in areas where previously the incidence of inflammatory bowel disease was low, in those areas the incidence is rising as well. So why are we seeing the rise of incidence of inflammatory bowel disease in these areas where previously the incidence and prevalence was low? Well, there is a hypothesis known as the Hygiene Hypothesis that tries to explain this rise. And according to the Hygiene Hypothesis, it is happening due to improvement of food storage, reduction of food contamination, and also due to alteration in the gut flora of the population living in these geographic areas. And the hypothesis suggests that all these things are resulting in inadequate development of regulation process or regulatory process that used to limit mucosal immune response. So since now there is inadequate development of the regulatory process that used to limit mucosal immune response, so now there will be inappropriate mucosal immune response, and that will lead to inflammatory bowel disease. But also remember, this is still a hypothesis and it still lacks a lot of details. However, one interesting observation do support this hypothesis, and according to that observation, the rate of inflammatory bowel disease is low in areas where helminth infection is endemic. So this interesting finding does support that hypothesis. But still there are a lot of details that need to be discovered to know whether this hypothesis is actually correct or not. So now that we have talked about the epidemiology of inflammatory bowel disease, now we will move on and talk about the pathogenesis of inflammatory bowel disease. Regarding pathogenesis, the precise causes of inflammatory bowel disease are still not well defined. However, it is believed that inflammatory bowel disease occurs due to combined effects of multiple factors. And I have also written those factors here, so they will include genetic factor, mucosal immune responses, intestinal epithelial defect, and gut microorganism. All these factors will contribute in the pathogenesis of inflammatory bowel disease. And now let's talk about these factors one by one. So the first factor was genetic factor. Now, population-based genome studies have shown more than 160 inflammatory bowel disease associated genes. Moreover, several of these genes also overlap with the genes that are involved in immune response against mycobacteria, particularly against Mycobacterium tuberculosis and Mycobacterium leprae. And this overlapping may explain why we see overlapping histopathological findings in inflammatory bowel disease and also in Mycobacterium tuberculosis and Mycobacterium leprae infection. But one thing you have to remember, any one or single gene only increases small amount of risk for inflammatory bowel disease. So this is a multifactorial pathogenesis, and always remember that thing. Now, among the genes, this particular gene, nucleotide oligomerization binding domain 2 or NOD2, this gene polymorphism is strongly associated with the pathogenesis of Crohn's disease. And you can also see in the board I have also written two other names. These two genes are also important. They will include ATG16L1 and IRGM. So just remember the names of these genes for your multiple choice questions. Now, one thing you have to remember, the risk of inflammatory bowel disease increases when one family member is affected. In case of Crohn's disease, the concordance rate among monozygotic twins is around 50%. In case of ulcerative colitis, the concordance rate among monozygotic twins is around 15%. So from this we can see that genetics play a much more dominant role in Crohn's disease compared to ulcerative colitis whenever we are considering the concordance. Now, what do we mean by concordance? Now, concordance in genetics means the presence of same traits or same presentation among the both members of a twin pair. So that is concordance. So now that we have talked about the genetic factors, now we will move on and talk about the next factor, and that was the mucosal immune responses. Now, defective immune regulation and derangement of mucosal immune activation both can result in inflammatory bowel disease. So let's explain these two components one by one. Now, under normal condition, there is a lack of immune responsiveness to dietary antigens and to the commensal flora that are seen in the lumen of intestine. And this lack of immune responsiveness or immune regulation is achieved with the help of certain CD4 positive T cells that can liberate some anti-inflammatory cytokines, for example cytokines like interleukin 10 and TGF-beta. However, when this immune regulation mechanism is defective, there will be uncontrolled inflammation, and that will lead to formation of inflammatory bowel disease. The second thing that we talked about was derangement of mucosal immune activation. And in order to explain that, you can see that I have also drawn a very simple diagram in the whiteboard. So first, let's see what we are dealing with here. So on the top, this is the lumen of the intestine. Here we can see the epithelial cells, and beneath the epithelial cell we can also see some antigen presenting cell. For example, we can see a dendritic cell. So what is happening here? Drawn in red color, these are bacteria, so these are rod shaped bacteria, and we can also see some coma shaped bacteria or cocci as well. So this is a very simple diagrammatic image. So we are denoting that there are a lot of bacteria on the luminal side, and bacterial components are getting inside the gut wall, and these components are taken up by the antigen presenting cell, which in this case is a dendritic cell. The dendritic cells will then process those bacterial components, and then with the help of MHC molecule, the antigen presenting cell will present the antigen to T cell. At the same time, the antigen presenting cells will also liberate various types of cytokines, and that will help in differentiation of these CD4 positive T cell. Now it can differentiate in various ways. So in susceptible host, these things can happen, and then if the CD4 positive cell is differentiated in the T helper 1 pathway, that T helper 1 cell will release interferon gamma. Interferon gamma will activate macrophage, and that will then liberate tumor necrosis factor. T helper 1 cell itself will also release tumor necrosis factor as well. And all these things will have a role on the epithelial cell that will increase the permeability of the tight junction in between the epithelial cells. Okay, so more and more bacterial products can now enter, and this cycle will repeat, and this will result in various types of inflammation. So that is one mechanism. And also you can see that sometimes the T helper 2 pathway can be activated. And what will happen then? T helper 2 cell will release certain things, for example interleukin 13, 4, 5, and then they will again act on the epithelial cell. And always remember, T helper 1 cell response is particularly important in case of Crohn's disease, and that causes transmural granulomatous inflammation. Now what do we mean by transmural? It means the entire thickness of the wall of the intestine will be involved, and there will be granulomatous inflammation. So those are characteristic findings that we will see in Crohn's disease, and that is the mechanism. And at the same time, whenever T helper 2 cell pathway is activated, that will result in more superficial inflammation that we see in ulcerative colitis. And also you can see that some T helper 17 cells will also be produced, and they will also have a role in pathogenesis of inflammatory bowel disease as well. For example, they will have role on neutrophils as well. So this was in short about the mucosal immune responses that are having a role in the pathogenesis of inflammatory bowel disease. The next factor in pathogenesis of inflammatory bowel disease was epithelial defect. So there may be barrier dysfunction, which can include defect in the tight junctions among the epithelial cells, and also there may be polymorphism in the extracellular matrix protein, and also polymorphism in matrix metalloproteinase enzymes. And all these defects are associated with development of inflammatory bowel disease. The last factor in the pathogenesis was the gut microorganism, particularly the microorganism that are populating the mucosa of the intestine. Now these microorganisms can affect the innate and adaptive immune response, and they can also influence the pathogenesis of inflammatory bowel disease. So this was in short about the pathogenesis of inflammatory bowel disease, and now we will talk about the morphology. And since 2 diseases comprise inflammatory bowel disease, so first we will talk about the morphology of Crohn's disease. Now Crohn's disease can occur in any part of the intestine, however it is most common in the terminal ileum, ileocecal valve and cecum. Regarding the gross morphology of Crohn's disease, you have to remember these 3 important features. So they will include skip lesion, serpentine ulcer and cobblestone appearance. So let's explain these 3 things one by one. Now what do you mean by skip lesion? These are multiple, separate, well demarcated disease areas with intervening unaffected areas. to explain that thing, you can see that I have also drawn an image of a Crohn's disease. So this is the intestine. Surely you can see that these are the small intestine. Then here we have the cecum, appendix, the ascending colon, transverse colon, descending colon, and so on, right? So the affected regions are drawn in red color. So you can see that Crohn's disease in this particular case has affected a lot of regions. However, there are some intervening unaffected regions, right? So this is why, as if these parts were skipped, and that's why this type of lesion is known as skip lesion. Now, besides skip lesion, we will also see some other findings. For example, the serosa, the outermost layer of the affected region, will be inflamed and granular, and also there will be creeping mesenteric fat, particularly whenever there is extensive transmural involvement. The entire thickness of the gut wall is getting involved. In those cases, we will see creeping mesenteric fat. So also remember that thing. Moving on to the next feature, and that was serpentine ulcer. Now what do we mean by that? Initially in Crohn's disease we see some punched out mucosal ulcers, and those are known as aphthous ulcer. But later those ulcers will coalesce along the long axis of the gut and they will fuse, and that will give a serpentine nature. So that's why it is known as serpentine ulcer. And also remember, we will also see another finding, and that was cobblestone appearance. Now what do we mean by cobblestone appearance? The thing is, the affected areas, or the areas where we will have diseased tissue, those areas will be depressed relative to the normal mucosa. So we will see alternate areas of depressed and raised portion, and that will give cobblestone appearance. So that is another important gross morphological finding to know. So now we will move on to the microscopical findings of Crohn's disease. Regarding the microscopic morphology of Crohn's disease, these are the important features that we will see. So there will be mucosal inflammation and ulceration, and also there will be cryptapses. Now what do we mean by cryptapses? Clusters of neutrophils within the intestinal crypts are known as cryptapses, and repeated destruction and regeneration of the intestinal crypts will result in distortion of the mucosal architecture. Normally the intestinal crypts, as shown in this image, are straight and parallel to each other, but whenever we will have Crohn's disease, due to repeated destruction and regeneration, that orientation will be lost and they will have a bizarre orientation, as shown in the right crypt here. So this is a normal crypt and this is an abnormal, bizarre looking crypt, and these are seen in Crohn's disease. So recall that these are the lining epithelium and they are forming crypts. However, this one is normal, straight, parallel, and this one is abnormal, and this one is seen in Crohn's disease. We will also see different types of metaplasia in Crohn's disease. For example, Pseudopyloric Metaplasia and Paneth cell metaplasia. Now what do they mean? Well, in Pseudopyloric Metaplasia we will see some cells that are normally present not in the intestine but in the stomach and in the pyloric antrum of the stomach. So those cells, those gastric antral appearing glands, will be now present in Crohn's disease due to metaplasia, and that type of metaplasia is known as Pseudopyloric Metaplasia. We can also see another type of metaplasia in Crohn's disease, and that is known as Paneth cell metaplasia, and this type of metaplasia will happen in those regions, for example in the left colon, where Paneth cell is normally absent. And one important thing you have to remember is this one, non-caseating granuloma. This is a very important hallmark of Crohn's disease. So these were in short the microscopical morphological findings in Crohn's disease. So now that we have talked about the morphology of Crohn's disease, now we will move on and talk about the morphology of ulcerative colitis. Now always remember the lesions of ulcerative colitis are continuous. Therefore, we won't see any skip lesion here that we had seen in case of Crohn's disease. So this image is denoting the distribution of ulcerative colitis. As you can see, it involves the rectum and also extends in a retrograde fashion proximally. Sometimes the entire colon up to this part can be involved, and that is known as Pancolitis. And sometimes the distal ileum, that is this portion, can also get inflammatory changes, and that is known as Backwash ileitis. So regarding the gross morphological findings of ulcerative colitis, the mucosa will be reddened, granular, friable, and there will be presence of some inflammatory pseudopolyps. And also remember that in ulcerative colitis we can see areas of extensive ulceration or atrophic and flattened mucosa can also be seen. Regarding the microscopical findings, we will see mucosal inflammation in case of ulcerative colitis, but always remember, unlike Crohn's disease where the disease distribution was transmural, in Crohn's disease the entire thickness of the wall was getting involved, but in ulcerative colitis the lesion will be limited to the mucosa mainly. We will also see crypt abscess here. There will be also distortion of the architecture of the mucosa. There will be mucosal damage, ulceration, atrophy. However, we won't see any fissure, nor any aphthous ulcer, nor any granuloma that we had seen in case of Crohn's disease. So these were in short regarding the morphology of ulcerative colitis. So now that we have talked about the morphology of both disease, now we will move on and talk about the clinical features. The clinical features of Crohn's disease will include intermittent attacks of diarrhea, fever and abdominal pain with asymptomatic periods lasting for weeks to months. Now, depending on the sites involved, in Crohn's disease there can be also malabsorption, malnutrition, iron deficiency, anemia, vitamin B12 deficiency and protein deficiency due to protein losing enteropathy. And in your textbook you will also see that in Crohn's disease sometimes there can be also extra-intestinal manifestation. They will include migratory polyarthritis, sacroileitis, ankylosing spondylitis, uveitis, cholangitis, amyloidosis, erythema nodosum, etc. So these are the important extra-intestinal manifestations that we can see in Crohn's disease, and this is very high yield information for your exam. And one thing you have to remember, that in long-standing cases of Crohn's disease that had involved colon, there is increased risk of colon adenocarcinoma as well. So there is increased risk of colonic adenocarcinoma in case of long-standing Crohn's disease that had involved the colon. So these were in short about the clinical features of Crohn's disease. Now we'll move on and discuss briefly the clinical features of ulcerative colitis. The clinical features of ulcerative colitis will include intermittent bloody mucoid diarrhea and abdominal pain, and these clinical features can persist for days to months. Extra-intestinal manifestations are also seen in ulcerative colitis patient as well, and they will include migratory polyarthritis, sacroileitis, ankylosing spondylitis, uveitis, primary sclerosing cholangitis, and skin lesions. And risk of colonic adenocarcinoma is also present in ulcerative colitis patient as well. So now that we have talked about the clinical features, now we will move on and discuss the differences between Crohn's disease and ulcerative colitis. So as you can see, I have written the major differences between Crohn's disease and ulcerative colitis in the whiteboard. So let's discuss these differences one by one. So first point was regarding the bowel region. So Crohn's disease occurs in the ileum and or colon, whereas ulcerative colitis involves the rectum and colon only. Moving on to the type of lesion, we have seen skip lesions in Crohn's disease, whereas in ulcerative colitis the lesions are continuous and diffuse in nature. Stricture is present in Crohn's disease and that is rare in ulcerative colitis. The walls of the affected part are thickened in Crohn's disease and they are thin in case of ulcerative colitis. Moving on to the microscopic features, we had seen that inflammation involves the entire thickness or transmural involvement is seen in Crohn's disease, whereas inflammation is limited to the mucosa only in case of ulcerative colitis. And fibrosis, serositis, all these things are marked in Crohn's disease and they are very mild to none in case of ulcerative colitis. And this is very important. Granulomatous inflammation or granuloma are present in Crohn's disease and they are not seen in ulcerative colitis, and fistula tract or sinus tracts can be found in cases of Crohn's disease and they are absent in ulcerative colitis. So these were in short the major differences between ulcerative colitis and Crohn's disease. So we are almost at the end of today's video. The last topic that we will discuss briefly is regarding the treatment of inflammatory bowel disease. Now always remember, unfortunately there is no complete cure for this disease. So the main treatment goal is to reduce the inflammation and to reduce the complications that can arise from long-standing cases of inflammatory bowel disease. So treatment will include diet and lifestyle modification, drug therapy, and also surgery may be needed. So in the drug therapy we will use anti-inflammatory drugs, immune system suppressors, antibiotics, etc. So anti-inflammatory drugs are in fact often the first step in the treatment of inflammatory bowel disease, and the commonly used anti-inflammatory drugs in inflammatory bowel disease are corticosteroids and aminosalicylates. Now we can also use drugs that can suppress the immune system suppressors, and as a matter of fact these drugs will also reduce inflammation. However, instead of working directly on inflammation, these drugs work on the immune system and prevents inflammation. So examples of immune system suppressors will include mercaptopurine, azathioprine, cyclosporine, methotrexate, etc. And also antibiotics are often prescribed, particularly if the patient had complaints of fever. That means there may be some underlying infection, and therefore antibiotics are prescribed. And antibiotics will also be helpful in healing the crypt abscess and the fistulas that we had mentioned. So the commonly used antibiotics in inflammatory bowel disease will include metronidazole, ciprofloxacin, etc. And one thing we have to remember, we can also use some other drugs as well according to symptoms. For example, we can use antidiarrheal medicine. Recall that diarrhea was a very common symptom in the patients of inflammatory bowel disease. The patients also complain of pain, so we can also prescribe them different pain relievers. Recall that many of them also has iron deficiency anemia, so iron supplement may be needed. If there was vitamin B12 deficiency, vitamin B12 supplementation may be needed. Some patients may also have malnutrition, and in those cases we have to provide proper nutrition as well. So these were the drug therapies, and if these treatments doesn't work, if the diet, lifestyle modification and drug therapy doesn't work, in those cases the physician may also suggest surgery. So this was in short about inflammatory bowel disease. I hope this video was helpful. If you like my videos, do comment, share, subscribe and let me know. And for my students, I will also recommend you to go through your textbooks to know more information. Okay, that's all for today. Until next time, take care and stay blessed. Thank you.